we are so happy that you all are here with us today. We were supposed to have this event back in March, and there was a snowstorm, so we're glad that the sun's out, and we were able to postpone. I have the pleasure today of introducing Dr. Absar. She is just an incredible physician and teacher and lecturer, and I've heard her many different times, and I think you'll be very engaged as you listen to her. So you can see her wonderful credentials that she has. She serves as our medical director of the Fox-Meyer Memory Clinic here at Copper Ridge. She's a diplomat in behavioral neurology and neuropsychiatry, and she's very involved on a national level as well and advocating from the neurology. She was recently on the Hill visits that the Neurology Association had. And I just wanted to give you a little background, some more background that you don't see on the screen. Prior to moving to Maryland, Dr. Absar practiced geriatric neuropsychiatry in Massachusetts. She was on the teaching faculty at Harvard Medical School, the University of Massachusetts Medical School, and Tufts Medical School. And this is the really fun part. She's also a registered yoga teacher and specializes in yoga therapy for brain disorders. And if you've ever been part of her brain disorders and yoga seminar, you know she has a passion for yoga as well. So without further ado, I'm going to have Nicole start. Thank you.
Thank you, Cindy. Thank you so much for coming, everybody. Just for the purpose of time, I wanted to request if we can wait for the Q&A at the end so I can finish up all my slides, just because of the time, but I have so much to cover. And some of the slides maybe duplicate, or some of the slides I may have to just skip it. So it doesn't mean that I'm skipping the entire topic. And also, couple of few things about this. This is a 4-part series. So I would really, really encourage all of you to sign up for all 4 parts, because what I'm doing is covering the entire curriculum on neurocognitive disorders in 4 sessions. So if you miss one of them, it's not going to be the continuation of the course. So I would really urge you to look up online for the Institute and sign up for all 4 series. So the first series today is, sorry, Jill. Allison, what did I do? Oh, okay, sorry. Oh, all right. So just for the purpose of a little review of neuroanatomy, brain anatomy, I'm not going to go into details on that, but just for the purpose of our education, I was going to show you a few parts of the brain that we're going to be focusing today. So today is our first series. So it is actually going to be covering the front part of the brain, which is our frontal lobe, and the part that connects the frontal lobe, which is called subcortical structures that involve basal ganglia, which is the movement part of the brain that makes us moving every day, as well as thalamus, which is our learning part of the brain. So the entire circuitry of the brain from frontal lobe to the thalamus controls how we work, how we plan entire day, how we manage the whole day. So I'm going to talk on that. So that will be our focal point for today. So in the domain of today's talk is attention and executive function. So I'm going to just focus on that. And then the second part, we're going to focus on the other 2 and 3, third domain, which is the visuospatial functioning, memory, as well as apraxia, agnosia, and some of the other motor planning and motor learning that is essential. All 4 of them get dysfunctional when you have dementia. So it is absolutely essential for every healthcare workers, whoever work with patients suffering from this sad disease, to understand all 4 domains, because neurocognitive disorder has a revolution in the past year. There is nothing called dementia anymore. Dementia is a politically incorrect term. It comes from a Latin word called craziness. So it is not a good way to tell our seniors and our patients, our loved one, that they are crazy. This is not a crazy illness. So we have eliminated the term dementia in the ICD-10 and DSM-5, started this year, with major neurocognitive disorder. So dementia is called now as major neurocognitive disorder, whereas MCI, which is mild cognitive impairment, is called as mild neurocognitive disorder, which is mild means it's not major enough to cause dysfunction. So it's the same thing as MCI. Okay, so with that, I'm going to go to my first slide, which is the brain slide. And here, I just wanted to show you, I don't know the lights, if you can see everything, or should we switch the light off? This is the cortex. This is the part of the brain that I will be talking about. This is the frontal lobe. This is the entire part, is the intellectual part of the brain. And this is the learning part of the brain that I was talking, the thalamus. And these are the basal ganglia structures. And this is the coordination part of the brain, cerebellum. So functionally, we have three parts of the brain. And this is just for introduction. So you don't have to write, you don't have to do this. Just for the purpose of understanding, I'm just going to quickly review. These three parts, the first part is called forebrain. It covers, these are the three parts, which is the intellectual brain or cerebrum, which makes us different from higher animals like dog or cat. Because of this, we are functioning, we have the idea of what we are doing, hopefully not all the time, about the judgment, decision-making power, making priority in life. These are the part that controls that. So when you have dysfunction on this part, mostly we call neurodegenerative illness, like Alzheimer's disease, Pick's disease, Lewy body disease. So we're going to talk a lot about that. Whereas the basal ganglia, basal means base, ganglia means collection of neurons. It is called basal ganglia because it is situated at the base of the cortex, meaning underneath the cortex. And it's collection of neurons that controls a chemical called dopamine. When you lose that chemical in that part of the brain, the disease we get is called Parkinson's disease, okay, and Huntington's disease. Those are the movement disorder. We also, this part is connected intimately with frontal lobe. So when you have dementia involving frontal lobe, as the disease progresses, it also involves basal ganglia. In frontotemporal dementia, it happened earlier. In Alzheimer's disease, it happens a little later. So in the end of each dementia, you all will have gait disturbance as well as Parkinsonism. And that's just part of the illness progression. And then the last part is thalamus, which is the learning part. Nothing goes to our brain without checking into thalamus. So thalamus is like a gatekeeper. You know how you have to go to a big mall, you have to go through a revolving gate, revolving door, most of the mall, I think. Thalamus is like the revolving door. So nothing from periphery goes to the brain without checking in. It's like a check post, except only one special sense, which is olfactory, which is sense of smell. It goes directly. It does not go through the thalamus. Other than that, every special sense, including touch, pain, temperature, anything that goes to the brain has to be controlled by the thalamus. Thalamus also involves a learning process. So it's part of the limbic system, which is our memory system. So disease like Alzheimer's disease like alcoholism and Korsakoff's psychosis, Korsakoff's disease, Wernicke's disease is also degeneration of the thalamus. And that's why you get the memory problem and learning problem. All right, and the second part of the brain is called midbrain or mesencephalon, which is mostly in the basal part. It controls most of the cranial nerves, that nerves that controls our eyes, controls our taste, so I'm not going to go details on those today. And finally, hindbrain is the brainstem, which is comprising of medulla, pons, and cerebellum. This is basically a center for few things. For our purpose, we all have to know that this is the area that has some kind of neuron that connects upward, connect to the frontal lobe. And these neurons are the reason that we wake up in the morning and go to bed at night. This is called reticular activating system, RAS, which maintain the circadian rhythm every day, the day and night rhythm. And they have melatonin in there. So melatonin also involved in sleep-wake cycle. When we have dementia, we don't just lose the memory molecule. We lose every molecule in the brain. So when you lose the melatonin, what happens? We can't sense day and night, and we call it sundowning. So sundowning is a normal phenomenon as the disease progresses in dementia because of melatonergic dysfunction. So melatonin controls that. So in the, our loved one or our resident have really hard time sensing the day and night, especially if it is really in a nursing home. Some of the nursing home setting is very dark inside, and it makes even worse. It even make worse in the winter time when you already have the evening coming early. So this is just a summary of what we talked. This is just the summary of the intellectual part of the brain. So this is the frontal lobe. This is the parietal lobe. We're not going to talk about that. We're going to talk about it next session about the parietal lobe, which is essential part of our conversation, because this is the part controls our understanding, our connection from visual eyes with our spatial part. This visual spatial functioning is essential for navigation in our personal space, the thing that we take granted. So if I have a walker there and I need the walker to walk, my spatial brain tells me how far is the walker from me. Okay? If my spatial brain does not work, what's going to happen? I don't have an understanding how far this walker is from me. So I may want to reach out to the walker, but it's too far. I cannot reach, and I'm in bed. So what do happen? I'm going to fall. This is the reason for falling in dementia. So falling is a functioning, it's not a preventable. I mean, we can prevent the injury from fall, but falling is a symptom. It is a sign of progression of dementia. So you cannot stop falling because this is how the disease progresses. And visual spatial function also essential for driving, so that when you drive, you can't have an understanding how far are you from another car, how far are you from the curb, are you in between line. This is the brain, this is the spatial brain that determines that. When you don't have that brain, you're going to get loose, you're going to get lost, you're going to get disoriented. It happened in the road. So I am from Boston. Yeah, I drive almost every month, not every month, but at least maybe every other month. So when I drive, I take 95 north, yeah, because my spatial brain is telling me Boston is north. If my spatial brain wasn't working, I may be driving for 40 years, 50 years, 60 years, but I will get to the car and I didn't know whether I should take 95 south or 95 north. And I may go 95 south, end up in Florida, not Boston. And that's what happened when your spatial brain does not work. Okay? All right, but we're not going to talk about it today. We're going to talk about that next session. All right, occipital, which is our visual brain. So visual brain controls our eyes. A type of Alzheimer's disease, and that would be our conversation on the third series. Third series is all about Alzheimer's disease. Alzheimer's disease also revolutionized in last year. We used to know Alzheimer's disease means memory. It's just one type of disease. We were so wrong. We were so wrong because now we know there are at least 5 different types of Alzheimer's disease. Only one kind of Alzheimer's disease, only one type comes with memory problem. The other 4 does not start as a memory problem. One of the problem, the type of Alzheimer's disease that has been more in the literature now. I actually just got back from Boston from our Academy of Neurology meeting last month. And this was one of the topic of the year, that a type of Alzheimer's disease where the shrinkage more happen in this part of the brain, the visual part of the brain and spatial part of the brain, instead of memory part of the brain. So these folks don't have any trouble with their memory in the beginning. They have trouble with vision. So these are the folks end up in eye doctor rather than a neurologist, at least 5 to 10 years, because they think they have macular degeneration to cataract to glaucoma, which they may have because of the age. But they have multiple surgeries, but nothing better, nothing gets better. and they can't see properly. They're feeling like they're getting lost in driving. After way long going through the doctor, then doctor gave up and say, you don't have an eye problem, go and find a neurologist. By then it's too late, because by then they already started having other problems like memory and other executive function. And this is the type of Alzheimer's disease. We call it PCA. P stands for posterior, meaning back. C stands for cortical, means cortex. A stands for atrophy, means shrinkage. So shrinkage in the back of the brain is called PCA variant of Alzheimer's disease. Okay. Next slide is just a summary of the functional part. I already talked about it. So frontal lobe is the logical part of the brain. Emotional part is called limbic system. And sometimes for simplicity, I make fun of these areas. So the frontal system and limbic system is like daddy and mommy in a house. I don't want to stereotype all the fathers, but most of the fathers figure is the more logical, yeah, in the house. They're more about, logic and all things. Mommies are very emotional sometimes. Again, this is more oversimplification. But so when a teenage daughter comes dating somebody, the first question daddy may ask, does he make enough money to support you? More logical question. Well, mommy may ask, oh, I'm so happy you have found some love, So our body is always in a homeostasis. We have to have a balance between the logical brain and the limbic brain. When you lose the balance, that's how a lot of the psychiatric disease starts. When you have too much limbic activity and too little frontal activity, we see mood disorder. Depression is more common in those. When we have more of the limbic system, more of the frontal system, less of the limbic system, we see that in a disease like FTD, frontotemporal dementia, where they are disinhibited, they have no empathy, they have nothing, they don't care about other people. They can tell you up front, in front of you, oh, you look ugly, because they cannot sense, they cannot filter things that we don't usually say in public. This is the FTD. This is called Pick's disease or frontotemporal dementia. Oops, all right, I lost it again. I hope I don't know every time something happens, what did I do?
Sure, let me figure it out.
Okay, I should not do this, but let's keep talking. So our talk today would be attention and executive functioning. So these are the domains, I just talked about it. So attention is one of the domain, then memory, language, visual, spatial, and executive function. For the purpose of the talk, I'm going to combine the executive function and attention together because both of them serve by the same structure of the brain. So this is just a summary that I talked about. So when you lose the memory part of the brain, we call hippocampal. Again, we're not talking about that this morning. We call amnesia. When you lose the visual, spatial, and motor part of the brain, we call it apraxia. When you lose the visual object recognition, which is, again, we're going to talk on the second series, we call it agnosia. When you lose the language part of the brain, we call it aphasia. When you lose the attention and executive function of the brain, we call it dysexecutive syndrome. So these are the different cognitive domains. You have to have at least two or more together to qualify for the diagnosis of so-called dementia, what we call now major neurocognitive disorder. So you can have that in any combination. You don't have to have memory. So now you know memory does not need to be involved for a diagnosis of dementia. So when you do a testing for traditional memory scale, like Falstein's mini mental state examination, Falstein taught me. So I know everything from whatever I know is because of Falstein, because he was my teacher. But even though he created that mini mental, he himself said, this is primary screening for amnestic variant of Alzheimer's disease, meaning Alzheimer's disease that has a presentation of memory, because it does not really screen other dementia that good. So you can have a mini mental score of 30 out of 30, but you can be profoundly demented because your problem is not memory. Your problem is the other 4 digits. So that's what there are other tests that you have to do, and we can talk about those as we go along. So another summary is the dementia is a diffuse disease, meaning you have to have more than 2 or more of those. What happens if you only have one of those domains affected? Happens in stroke. Patient who has a stroke, they don't have multiple effects sometimes. They only can lose the language and they become aphasic. Or they can just have a trouble with the memory. I had a patient in Boston. He was a 28-year-old cocaine addict. So he shoot cocaine, and cocaine is vasoconstrictor. So it constricts the blood vessels. It went to the posterior cerebral artery and middle cerebral artery. Middle cerebral artery supplies the hippocampal area. So it should and occlude the vessels in the memory part of the brain. So as a result, he had a stroke in that part. So he did not have a paralysis or anything else. All he has is loss of memory. He could not remember anyone. He could not learn any new information. So he has amnestic syndrome, but he is functioning fine. His language is fine. He has recognition is fine. His executive function is fine. So do you call it dementia? No, because you only have one domain involvement. So we call that amnestic syndrome. So this is how you differentiate focal disorder from diffuse disorder. So dementia and delirium is a diffuse disease, meaning you have to have global problem, not one. Whereas these are focal disease. That can be from a stroke, that can be from a tumor, that can be from a brain injury, something that focally only attacks, not globally attack the brain. So these are the diffuse disease. So if you happen in acute states, abruptly we call it delirium. If you happen in subacutely, we call it reversible dementia, meaning dementia that is caused by systemic medical condition like thyroid condition, like vitamin B12 deficiency, like syphilis, like Lyme disease. A lot of it goes on and on. That's why dementia workup is not just a workup of the brain. It has a major workup to rule out each of those different diseases, because we don't want to overdiagnose a neurodegenerative disorder without ruling out something that can be preventable, something that can be treatable. And then finally, the chronic disease is the dementia. All right, so this is our topic for frontal subcortical domain. Remember what I said, frontal subcortical means, sub means under, so under the cortex, meaning remember the basal ganglia and thalamus we talked about. So this disease, one of the example of dysfunction of this type of dementia or this type of domain would be what? Frontal lobe get disrupted in dementia like FTD, frontotemporal dementia. There is a type of Alzheimer's disease. Again, we're not going to talk today. We're going to talk on the Alzheimer's disease series on third, I think it's the series number 3. But there is an Alzheimer's disease variant similar to PCA variant where the problem, the shrinkage actually more prominent in the front part initially. So they don't have problem with the memory either. What they have similar problem like frontotemporal dementia, personality and behavior problem or language problem. But they get misdiagnosed either as a psychiatric disease or they get misdiagnosed as a frontotemporal dementia because they are also younger. They are not older. They are like in their 60s, sometimes even 40s and 50s. So it is a major, even for a good neurologist, it is very difficult sometimes to differentiate between the frontal variant of Alzheimer's disease and FTD, frontotemporal dementia, or language variant of frontotemporal dementia. We call it PPA, primary progressive aphasia, where you get just aphasia. You have no behavior problem. From the type of language variant of Alzheimer's disease, which we call logopenic Alzheimer's disease. Logo means language, penic means penia, means deficiency. So logopenic means deficiency of language, and that is another variant of Alzheimer's disease. So just to give you so many types of dementia or neurocognitive disorder, that's why I wanted to encourage you to complete the course and make sure you can relate every day with everything that I'm saying when you see a patient. So the first question you ask to yourself, anybody can be a neurologist. Anybody, I'm serious. You can at least get a good history. If you talk to the family, first thing you ask, because our caregivers are so instrumentalized, dementia and memory, so when they come to see you, all they say, my loved one has memory problem, maybe getting dementia. But forget the other domain, because we are not instrumentalized in our brain to call those as a dementia. So your job is, you say that, I understand memory is a problem. Let me ask you though, forget about some kind of label or anything. Just describe the behavior. Just describe how things started. What was the first thing you noticed? So sometimes I hear, oh, well, the first thing actually noticed, we went to a dinner for Thanksgiving with the entire family, and my father is a accountant, but he could not figure out how much money to give tips to the waiter when the bill came. So think about that. It's not a memory problem. It's an executive function problem. It's to figure out day-to-day activities. So if you can't do that history, you may overdiagnose Alzheimer's disease. But this was a typical frontotemporal dementia. That was. So always go through the initial. What was the first symptom and how the chronologically started. So was the executive function first? Was the mood? Depression was the first problem. If that is the case, sometimes you see what they call syndrome of 3M, mood, motivation, movement, and gait. And that kind of things we see in stroke-related dementia called vascular dementia. What is vascular dementia doesn't start with memory. It starts with mood disorder, depression. So they end up going to psychiatrists because they think they have depression. But depression was the first M, 3M, mood, memory, mood, movement, and memory. So memory is the last one they get. And their memory is only short-term memory, not long-term. They can remember anything happened 20 years ago, but they can't remember what happened 3 days ago or an hour ago. And that is mostly, we call it vascular dementia. So the chronological history is so easy to take. Any nurse, any social worker, any caregiver, any physician can just talk to the patient's family or patient himself. Just say, tell me how everything started, rather than jumping into memory. All right? And forget about all that description, like, oh, well, you have this, they have drive. Don't do that. Let the patient's family talk, you just listen. And that can help you to make a formal diagnosis just by listening. All right, so we talk about, I'm going to skip this because this is more anatomy and I use it for a lot of the medical students training. But overall summary is frontal lobe has 3 different circuitry, anatomical circuitry. One of the circuitry is the back and posterior, back and up. This is the upper side and back side of the frontal lobe. This is the part of the decision-making part. So when you need a decision-making, like a consent or making a decision, making a judgment, this is the part that decides that. Dorsolateral frontal lobe. And then the there is a medial part, which is like one of the 2 hemispheres, the palm side of the inside of the frontal lobe, that controls our comportment. Comportment means our affect, our mood. So when you lose that, we see people get what they call apathy, almost look like depression. They become ebulic. Ebulia means loss of volitional movement, inertia of movement, or spontaneity. So they look like a zombie sitting there doing nothing. And sometimes they get overdiagnosed as depression. You give depression medication, they don't get better because this is a dysfunction of a chemical. Remember the dopamine? So same dopamine that causes Parkinson's disease cause apathy. So that's why one of the symptoms of Parkinson's disease is also mask face or apathy, lack of affect because of that. So the treatment of this type of apathy syndrome is not regular depression medicine, it's actually dopamine medicine. Same thing that we give for Parkinson's, same thing that we do. So there are dopaminergic antidepressant also available, which is like a Wellbutrin is a good one. Those would be good. But if you give a regular SSRIs or medication for depression, it's not going to work because their problem is not serotonin. Their problem is dopamine. Okay, so this is the frontal lobe that controls that. And then the base, orbitofrontal, orbit is here. So the part of the frontal lobe that is in between eyes, the base, that is the part that most commonly get damaged when you have a head injury. Okay, because when you have a head injury, your brain goes like this, yeah? So you have a whiplash or you have a damage to this part of the brain. This is the brain called orbitofrontal cortex, OFC, abbreviation. I like abbreviation, then you don't have to remember the whole thing. So OFC is the reason for things that we take granted every day, what to say in public, what not to say in public, what to do in bedroom, what not to do in bedroom, what is appropriate, what is not appropriate. This is the filtering part of the brain. When you lose that, you don't have any filter. You can be naked in the street. You can do the F word to anybody. You can scream. You can punch somebody right out of impulse because you don't have any filtering system. And this is the part does it. So most commonly we see that with TBI patient, traumatic brain injury patient a lot. But it also very common in frontotemporal dementia. A lot of the disease that involve a type of aneurysm called anterior cerebral artery aneurysm, which controls this, this anterior cerebral artery, which is in this area. If you have a stroke or a hemorrhage from that aneurysm, you can get a OFC, orbitofrontal syndrome. Or if you have a stroke in the front anterior cerebral circulation, you can have a orbitofrontal lobe syndrome. So there is a lot of ways you can get that syndrome, not just dementia, okay? All right, so these are the three regions of frontal lobe that connects frontal lobe from the deeper part of the brain that we call subcortical region. And these are the summary of the disease affected by frontal lobe, okay? So we talked about TBI. So TBI can be two types, acute hemorrhage, acute brain injury, or brain injury that is not acute but happens in a cascade, slowly, multiple times. Okay, so one big head injury, we thought that you need in order for you to have a brain disease. We are wrong, because now we know, looking at all the football players, that you don't need to have a big brain injury. You can have successive type of small brain injury, which is so mild that you don't even sometimes go to hospital, because it's called subconcussive illness. Sub means under. So it's not even qualified as a concussion sometimes. So as you can see, the football players, sometimes they wake up, they get up and they start playing. Now we have a good rules in the NFL because we have sports neurologists who are on the spot and guide when patients should return to or the player should return to the ground. So because of that, now we can identify early all kind of subconcussive injury of the brain. You don't need to have a football player. It can happen with children and it can happen with elderly because of multiple falls. So every time that you're falling, you don't even send them to the hospital sometimes because they are not losing consciousness. They don't have any apparent injury. But multiple of those falls make what they call a changes in the protein in the cell, the protein called tau protein, T-A-U. Tau protein is the cause of a lot of dementia, including frontotemporal dementia, including CTT, chronic traumatic encephalopathy, which is the disease that football players get, or chronic concussion results in. Tau protein along with amyloid together cause Alzheimer's disease. So tau protein is the indicator how the dementia progress, where amyloid caused the disease in Alzheimer's disease. So if you have just the problem with amyloid, there was no problem with tau, then you may have Alzheimer's, but it would have been static. It's not going to move. So which would have been good because you're not going to see any decline as the disease progresses. The decline is more with the tau. So tau make the more progression, where amyloid makes more of the disease onset. So now you know, even if you have an Alzheimer's disease, more you fall, more they're going to progress because you're going to have more and more tau in there, yeah? So it doesn't have to be Alzheimer's. Any disease will have. But pure tauopathies are FTD. Frontotemporal dementia is a pure tauopathies, meaning they don't have problem with amyloid. They only have problem with tau. so as CTT or chronic traumatic encephalopathy. These are the other disease that affects the frontal lobe. We talked about the stroke. Major stroke that I talked about, we never miss those because they have a major clinical sign. Problem becomes the minor or micro stroke, which we call lacunar stroke, because that doesn't sometimes have any symptom. Patient doesn't even know they have a stroke. And sometimes those strokes are incidental findings. Sometimes we do the scan, and these radiologists who were trained in the at least 10, 15 years ago, they didn't even know what to actually tell whether it has any significance. But now we know these microinfarcts are essential for connection of the brain, for the brain to talk to each other. So one of the criteria now, you don't have to have multiple stroke for vascular dementia. You don't have to have a major stroke. You can have minute, multiple patchy infarct that can even cause dementia, because you need to have a strategically, it's all about location, 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 like real estate, you know. So if you have a location of these really, really great location where memory or executive function is centered, if you have infarct in those areas, you don't have a major stroke. You don't need a major stroke. But if you have a stroke in the, say, example, medulla or brainstem, you may lose sleep cycle, you may lose some of the functioning like paralysis or bad, but you may not have major dementia symptoms. So it's all about location. So I'm going to spend a little time on a attention description. Attention, you all know ADHD is a childhood disease, sometimes we call. Attention is a dysfunction of a chemical, is dopamine. So dopamine is the reason of happiness. Everything that we are happy about comes from dopamine. So dopamine is the cause of depression, dopamine is the cause of apathy, dopamine is the cause of inertia of movement, lack of movement, called Parkinson's disease. When you have too much dopamine, that's not good either. Too much dopamine, it makes you psychotic, makes you really what they call schizophrenia. So schizophrenia is a too much overreactivity of dopamine in your system. So Parkinson's is one end, schizophrenia or psychosis is the other. So this traditionally, all the neurologists and the psychiatrists have struggled balancing medication for either schizophrenia or people suffering from Parkinson's. Because remember, Parkinson's medication is what? Dopamine. Cinemat and all the medication that we basically you increase the dopamine. What happens if you have too much of that dopamine? You're going to be psychotic. And the same thing happened with schizophrenia. It is too much dopamine make you hallucinate, make you delusional. So what do you give the antipsychotic medication to decrease the dopamine? If you make it too little dopamine in the brain, too much decrease, then you're going to have Parkinsonism. So this is the reason for really, really hard time. You need a fine adjustment with those diseases to do that. So dopamine is the reason for attention. I'm going to throw a test. This is a great test that we do as part of our neurocognitive testing. It is a test for sustained attention. I'm going to see how good are you doing today in my lecture series here. So this is a test for you. All right. All of you, look at this slide. I want you to read the color, not read the text. Do not read the text. Do not read what it says. You got to read the color. All right, start from here. Ready, go. Green, blue, yellow, red, yellow, red, green, blue, blue, green, yellow, red, blue, yellow, red, green, red, green, blue, yellow, yellow, green, blue, red. Good. Wow, I am so proud of you. You did pretty good. Oh, that was good. So this is what we need every day. It's called divided attention. This is how we survive every day. We do multitasking every day. we are so much, instrumentalized society, especially American. We do everything multitasking. We have on the phone, sometimes talking to work. We do something on the other hand. We do a couple of these on the other hand. That's how we survive. We are a multitasking society. So I'm going to give you a little bit of fine history. I mean, I always talk about this. So here I am in Boston. So I used to live in Plymouth, which is way outside, and worked in downtown Boston. So it's like an hour every day, but I loved it. I don't want downtown area. So I lived there, but the traffic was terrible. So one day the traffic is so bad that I'm stuck on 93. It's a long highway goes to the Boston on the right hand side. So nothing is moving. It's like everything jammed. So there is another car on my left hand side, and that is also, nothing moving. So that's also sitting there. There is a really tall blonde girl. She's beautiful. She's just sitting driving the other cars, the car on my left side. So I'm looking at the other side of and looking at her, and so she's doing on her right hand, she's doing lipsticks, putting the lipstick on. On the left hand, she's just doing a little bit of mascara and make sure that's correct. And then she's going to have a sip of water on the other side. She's doing like a multitasking while she's sitting there in the car. I was so impressed. So I was looking at her. I was looking at her and I said that you got a beautiful frontal lobe. And she looked at me like, what? So this is the reason for multitasking. So think about, this is the part that regulates us. This is the part that makes us multitask every day. We are so spoiled. We are. We take everything so granted. We don't even realize how hard it is to multitask every day. When you wake up, what do? You go to the bathroom, you look at the mirror, you look at yourself, oh God, I look terrible. I have to take a shower. You have to take a shower, and then what do you do in the shower? You have to do the brush. How do you toothbrush? You have to rinse the brush. You have to put the paste. You got to do that. Rinse again. These are multitasking work. You do the shower. You put the soap, rinse the water, put the shampoo, put the conditioner, put these. These are multitasking. We don't take it. We take it as a granted, as if like nothing. You don't need the skills to do that. It is multitasking. When you don't have a frontal lobe working, these are a challenge every day. Okay? So when you work with someone suffering from dementia or any type of neurocognitive disorders, these multitasking is so hard for them to do. So don't expect that Mr. or Mrs. Smith will do everything as you tell them to do. You got to cue them one step at a time. You cannot tell them, go and rinse the water, have some soap, come back and do the towel. It's too many information, too much information. You have to do one step at a time. So this is what happened. We see Mr. Smith started with the rinse, but is standing there with the soap, doesn't know what to do next. These are called sequential tasks needed. This part of the attention test, this part of the frontal lobe functioning. So without that, we cannot function every day. So when you have a frontal lobe dementia, whether it is a frontotemporal dementia or a stroke in the frontal lobe, or had a head injury in the front, whatever is the reason, or a tumor in the frontal lobe, whatever is the reason, if your circuitry in the frontal lobe does not work, the first thing you will see, of course, you will see changes in behavior and personality or language, but most common symptom would be executive function. So they can remember anything. They don't have memory problem. They can even drive because they don't have the visual spatial, because remember that is in the parietal lobe. So their parietal lobe is fine. It's only the frontal lobe is they affected. So all they cannot do, they cannot function in their home life. They cannot take one step to the other. And these are the people never get diagnosed as dementia because by definition we have to have memory problems. So we do Falsten's mini mental, they do 30 out of 30. That's not their problem. So they do not get a diagnosis, so they don't get any benefit of dementia, any care that they need. And the family get frustrated. They go to the doctor's office, but they don't get a diagnosis. The doctor keeps saying, no, they don't have dementia, it's just aging, what do you expect? But caregivers know this is not aging. This is getting worse. And this is why people are falling. This is why they're not functioning. They're getting lost from their house. They don't get any services. So this is why we have to focus on this cognitive domain. This is why you have to understand memory does not need to be involved in order for anyone to call dementia. Okay? This is just one of the domain. You have 5 other domains. You can have any combination of 2 or more to call dementia. So memory doesn't need to be in there. So forget about only doing a mini mental. Forget about just thinking about memory testing is a part of dementia testing. No, you got to do executive function testing. There are testing that we can do. MOCA, M-O-C-A, is a great test, Montreal Cognitive Assessment Scale. It's a 30-point scale, and don't think about the points. I keep all the primary care doctors, even the neurologists, sometimes they focus on the point. They score these and these. Don't matter how they score, matters where they lost. Because think about somebody, a foreign national coming from, say, China or India or somewhere, and they have no idea about Carroll County. If I do a mini mental, 10 point of the mini mental, first 5 is our place orientation, where you are in the county, in the town. If they are foreign national, they have never been here, how would they know? So they score already 5 down, and the same thing will be happen. But they're not demented, they're just not familiar with this place. So that's why you cannot look for the points. Don't ever train your brain to look at the points, that how is the mini mental score. It doesn't matter. It only matters the score really good for follow-ups. So if somebody has a baseline of 30, you started RSF, now they are actually, or baseline is 20, you started RSF, is getting better, or they're stable, that helps. So it is score is good for comparing. But for the first time diagnosis, don't focus on the stroke. Focus on where they lost. So if they lost in memory, 3 point, and that is enough, although their score is still 27 out of 30. But you can see their main problem is memory. So always remember where they lost rather than the global score. Okay. So this is, we talked about the dopamine. This is how the chemistry of attention. And the other chemistry of attention is also histamine. Histamine is a chemical that is involved in a lot of anaphylactic reaction, like allergic reaction, immune reaction. When you have allergy or anything, the medication that we give is antihistamine, like Benadryl, all kind of thing, which is great for allergy. It helps with the itching and everything. But look what it does to the brain. Because histamine is essential to keep you alert and keep you attentive. So when you antihistamine means you completely cut off the function of histamine. What's going to happen? Your alertness will be less alert. You're going to make somebody demented overnight by giving this Benadryl or over-the-counter antihistamine. So one of the worst thing you can do for your elderly, doing cough medicine over the counter. Do not ever prescribe on those, because you can make somebody acutely delirious, but just by giving those antihistamine, okay? So these are really bad. Same thing happened with other medications like benzodiazepine or pain medication like OxyContin. So you have to be very, very careful what you give. So these are the fundamental talk of the symptoms of frontal subcortical domain. So we talked about the mood. So depression, patient can come to your office with either of those problems. It doesn't have to be all of them, but it can have some of them. So how do you screen patients who have a frontal lobe or executive function problem? Talk to the family. See what is the problem. Family may say, you know, they're really, their memory are not, we're not really worried about that. You know, he can drive. He has some mistakes sometimes here and there, but overall his driving is actually fine. And you say, then why are you here? What is the problem? His memory is fine. Driving is fine, meaning visual spatial functioning is fine. So what's wrong? Well, the problem is, I think he just forget and asking me the same question. I don't know if it is the memory or he just not have the ability to get fixated on one topic. Getting fixated is one of the first symptoms of executive function. They cannot move from one topic to the other. So I have patients who all they talk, I have a headache. That's all. And you probably end up doing $10,000 neurological workup, nothing you could find causing the headache. It's not the headache. They are cognitively inflexible, meaning cognitive flexibility is a function of executive function, frontal lobe, so that we can move forward from one topic to the other. We can't just cry one day and say, oh, I lost everything. We say that I lost everything, but you know what? I have something. Maybe I should focus on something. That's called cognitive flexibility. When I don't have that flexibility, all we do is focusing on one topic. So sometimes they can focus on either one topic. They can focus on somebody stealing from them. That's all they can talk. They can focus on, you name it, focus on something in their life, not able to do that, or asking the same thing over and over. That's actually not a memory. That's not just they forget. That's the cognitive flexibility. They can't move on. So somatic symptoms sometimes, physical symptoms sometimes is a big one. Like I'm not talking that we should not do workup for them, but make sure you document after you workup is all found nothing. And patients still coming. I had some patient that I used to see, he died recently. He was so cute. He was coming to see me and he will say, just help me with the headache. And then you distract the attention, headache is gone. You talking, there is no headache. But then it will come back. Just help me with the headache. So everything after 5 minutes, and you can change the topic with something. It's like the frontal lobe changed the topic. What happens if you don't have the frontal lobe? We have to be the frontal lobe artificially from outside to change the topic. So instead of giving the Tylenol or pill, of course, if it is a severe headache, of course you can give the headache med. But sometimes don't over-treat with the pain medication. If you already know this is a frontal lobe symptom, this is really not a headache symptom, then distract the attention, change the topic, make another move from one topic to the other. Maybe, let's go for a walk. I know you have a headache. Let's just go for a walk. Look at the weather. Look at this. Change the topic. Talk something. That headache would be gone. But unfortunately, it will come back again. But as much as you can do that flexibility by working as an artificial frontal lobe, because they don't have one. They lost it. This is why they are cognitively inflexible. They can't change the topic. They can't change the direction. They get fixated on one topic and can't move forward. Okay. And then falling we talked about, that is another big problem that involves the basal ganglia. So Parkinson's symptom, tremor can be symptom of this circuitry problem. Executive function, I think we talked enough. We talked about that. And then memory, they do have memory problem in this type of dementia. But their memory problem is so different than Alzheimer's disease. Because what happened is their memory is really short term. Their memory problem is what happened like seconds to few days ago, rather than what happened 20 years ago. If you ask them, where did you go to school? They will tell you more than, what do you happen with their first kiss when you saw your wife? They will tell you everything. They have no problem with those memories, but they have problem with 5 minutes ago what they ate. They have problem with their appointments. They have problem with their everyday tasks. And this is called working memory. Working memory is an online memory. It's the memory of every day that we take it for granted. So if I go to grocery store, I have a $100 bill and I pay $7 to buy a soap or something. I don't have to calculate 100 minus 7 equal to what? I have an online way of understanding the cashier will give me $93. I may count the $93, but I don't have to go like every, and that is our ability to do everyday tasks online. It does not involve the hippocampus, the true memory part of the brain. It involves the frontal lobe, the front part of the brain. So this is what I will end up finishing my topic with, giving an example of these two types of memory. So with this, frontal lobe is almost like, it is a CEO of an office, if you have a good CEO, not one of the corrupted CEO. of nowadays you see all the, especially with this administration. But I'm saying that if you have a true CEO or a administrator, what do they know? What do? They make sure the budget is appropriate. They make the priority for project for this year, what can wait for next year, what cannot wait. They monitor how the employees work, they reward them, they prioritize them, they give incentive to them, or they can also rationalize what the company should do, what company shouldn't do. They make the budget, they make the financial planning. These are executive functioning. So the CEO is almost like the frontal lobe of an organization. And our CEO is frontal lobe. So think about when you don't have the frontal lobe. It's like when you have no CEO in your office. Then everybody is dysfunctional. They're all going, they don't have anyone to controlling them. They don't have anyone to regulate them. It's like, I know I have to do a shower, but I cannot even plan how I do the shower. So I ended up doing nothing. I was just sitting there in the chair doing nothing. Ask them, have you taken the shower? No. Why not? I don't know. But they don't have this motivation. They don't have the way to start. They don't have the way to follow. This is called sequential task. The planning, organization, sequencing. These are called executive functioning. So this is like a CEO of the brain. The other part of frontal lobe is a secretary. So what happens if you don't have a secretary in your office? If you don't have secretary, you may have files because the secretary may be putting the file somewhere. If the secretary is out on vacation or sick, you come here, the files are there, but you can't find where the secretary put the file. And that's exactly happened in our healthy brain. When you have frontal lobe has a cabinet where all the long-term memory get categorized into storage. Okay, so memory is a multiple regional task. So hippocampus, the real memory part, like right now, all you listening to me, yeah, hopefully, your hippocampus is lighting, but your frontal lobe is lighting first, because frontal lobe is helping with the attention, focusing, and then hippocampus is lighting. But hippocampus is actually not storing anything that I'm telling you. Nothing. Until tonight, when you go home. When you go home tonight, when you fall in sleep, there is a chemical called glutamate. Slowly walk to hippocampus and ask hippocampus, hey hippocampus, what did you learn all day? And hippocampus will say, well, we went to Copper Ridge. There is a Dr. Absar gave all kind of jargon for neurology or whatever. And glutamate will say, do you want me to make some memory so you can remember later? Hippocampus is please be my guest. While you're sleeping, glutamate make the first step of memory. We call it long-term potential, LTP. LTP is the long-term memory formation. What happened? You did not sleep tonight. Glutamate never came to hippocampus. So sleep disorder can look like dementia. So when you don't sleep, so any sleep apnea, obstructive sleep apnea, can diagnose as Alzheimer's disease. I have a patient came from a very renowned primary care physician, and it's not primary care physician's fault, so I'm not blaming that doctor or anything. The patient came with a diagnosis of Alzheimer's disease. Family challenged the doctor actually. Family did not feel that the patient has Alzheimer's. So when the patient came, we did our dementia examination, and part of the examination was sleep studies. And sleep studies came with obstructive sleep apnea. We gave a CPAP machine, started him on a dopamine medication called modafinil, which makes us alert, awake. The patient still come, but they don't have the diagnosis of Alzheimer's anymore. That is already cured. So many patients with misdiagnosed with this type of treatable causes, that's something you can actually fix it, something you can actually do it. So this is how the sleep happens with the glutamate. What happened tomorrow? The hippocampus only little bit area, but we're learning so much every day. So by tomorrow, hippocampus doesn't have enough storage. It's like a little computer chip. It ran out of storage. So hippocampus then asks for help. Help, I have no storage. Frontal lobe the wonderful, generous part of the brain, say, you know, hippocampus, I have a lot of filing cabinets empty. I'm going to store your whatever you learn, which is true. Literally, frontal lobe has those storage cabinets. Frontal lobe then categorize them into each individual region. So like Dr. Absar's talk, credit card, these, that, like the way you file in your office. So 5 years from now, if somebody asks you that what did you learn from copper read going on that day, you say, oh, I don't know, let me ask my frontal lobe. And frontal lobe will say, oh, yeah, I stored it on that. Here is Dr. Absar's lecture. Here you learn. And what happened, the frontal lobe is on vacation. You store it. Secretary is out, so you have no idea where it is. And that is a type of memory disorder called retrieval deficit. It's like losing password when you store something in a computer. So everything is there, but you don't know where it is. So you need some cueing. If you get the cueing, you can actually find it. And that is called a subcortical dementia symptom. So any disease that causes that type of memory, like Parkinson's disease, frontotemporal dementia, vascular dementia, you can get cued, they can come back, they can return back, because their memory is retrieval, not learning. They can learn, but they cannot retrieve information. Whereas in Alzheimer's disease is a learning and retrieval. So it doesn't matter how many cues you give. Glutamate never came to hippocampus. They don't have the hippocampus. So they have difficulty learning any new information. So this is like the way, and this is the last thing that I wanted to finish up with. There's so many ways you can differentiate these diseases. So my take-home message, and this is what I will end up with today, is please do not focus on memory. Memory loss does not need to be the only symptoms for dementia. Remember all the domains. Forget about what the other doctor said or other doctor diagnosed. Whenever you see a patient, start from your own scratch detective work. That let me ask the caregiver how actually it started. What happened in the beginning? Just talking, just listening to them. And half of the time you already know whether it's more likely an Alzheimer's. Then you can do appropriate testing, appropriate brain scan, and then you will figure it out which type. Okay? And with that, I will stop.